South Africa yesterday formally entered the third wave of the coronavirus pandemic. But what exactly does that mean for you and I? In a moment, I'll be joined by the National Health Department's Deputy Director General, Dr. Nicholas Crisp, who will unpack all the facts and numbers, as well as give us a sense of the government's level of preparedness. A little later, he'll be joined by a panel of experts who will independently tease out all the relevant issues. The Watchdog starts now. Remember, you can connect with us and tell us your fears, hopes, and aspirations at the Watchdog SABC on Twitter, and to share your views on the SABC News Online Twitter, Facebook pages using the hashtag SABC News. Well, I am indeed joined by the Deputy Director General of the National Department of Health. Doc, good evening, and thank you very much for your time. Well, the question, I guess, is whether this third wave, has caught us by surprise, or is it something we knew would come at this particular point in time?
Good evening, Boya, and good evening to the viewers. No, I think there's been lots of statements for some time, knowing that we were going to enter into a third wave. Of course, one doesn't always know when that's going to start, but we've had some lead time now, and it's been pretty well reported in the media, the wind up to this third wave, with some provinces early entrance, and now, of course, they're catching on. So we are not caught unawares. And all the administrations in the public sector and the private sector have been through it twice already. They all have their preparations and their various programs in place, but it's still always a rough ride, and it's very difficult for the services when it arrives.
Okay, we'll get to preparedness in a short while, but very briefly, if you can, Doc, just take us through how we progressed to this third wave, especially the past 3 or so weeks.
So I'm not sure that I'm the right person to go into the intimate details of the of that portion of it, because I work more on the vaccination program. But I think we've been watching the cases rise, first of all, in the Northern Cape, and we've seen other pockets of rises in the statistics of cases and positive tests and of hospitalizations. And now, of course, in the major centers, particularly in Gauteng, the last couple of days, we've seen quite a serious rise in the number of cases and the percentage of positive tests that are being done and of hospitalizations. So there has been some lead time and some warning, but one never knows exactly what the shape of the curve is going to be like.
Now, I mean, the second wave came with new and more dangerous variants. The question, I guess, is whether we should brace ourselves for even more dangerous mutations in this third wave compared to the first and second waves.
Yeah, well, look, I think as people who work in the health sector, we're always vigilant, and there are programs that are watching the variants. And we have a very good monitoring system in South Africa where samples are tested. We've got very good capacity in this country to do that. So at this stage, we are not getting information about significant changes in the variants that we are already aware of. You know, they've all been renamed now, Alpha, Beta, Delta, and so forth. So the predominant variant is the one that was always known as the South African variant, or the Beta variant. And that's what we're expecting and experiencing mostly now. There's also the original virus still in circulation. So we have not heard of a new variant now. That's not to say we won't get one. And that's not to say that the other variants that have been imported into the country are not also being spread inside the country now.
Which then brings us to the vaccine rollout. Where are we right now?
Yeah, well, the vaccine rollout is, there are serious global challenges, as I'm sure the viewers are already aware. We have a vaccine program which started with the Sisonke program, which was targeted at healthcare workers, and it was a research program. So, bigger than a normal research trial, it's more a clinical rollout. And during that trial, 479,000 and something doses were administered to healthcare workers. That part of the program, or what we call phase 1, ended on the 16th of May. And they are still doing the final reconciliation. And obviously, because it was a research program, there will be further information about specifically what they found and what they were monitoring on other aspects of that program. On the 17th of May, the next day, the national rollout program commenced. Now, the first program was obviously a different vaccine to what we are using now. It's a Johnson & Johnson vaccine, and now we're onto a Pfizer vaccine, which is a completely different vaccine. It's different for the nursing staff. The dose is different. The vials are different. The storage conditions are different. So it's taken a little bit of learning to get it going. But fortunately, the systems that were tested during the Sisonke trial have proved to be resilient. And although we've had to change some sites, and the administration of the sites has obviously changed from a research protocol to a rollout, it has gone relatively smoothly. The first few days were difficult because of the switchover, and because during that switchover, we had to do manual uploads of the SMSs for the scheduling of appointments pushed from the center. And that had to be done because of the short timeframes and the changeover from one program to another, while we had the staff and the administrators at the vaccine sites trained to use the new items on the vaccine rollout program scheduling system. That has now fully kicked in, and sites, when they got what we call go live or are activated to do scheduling of appointments, they control their own scheduling now, and they have a lot of leeway to manage that scheduling. It comes with its challenges because hopefully the people at those sites are properly trained and know what they are doing. And so from time to time, there are errors made, and it's getting better and smoother every day.
Just a few things arising from your very last statement, Doc. One is just on phase 1. Yes, you did say you're busy with a reconciliation, and we will know this a little later. Have there been any preliminary results or things that you can speak to?
Well, we knew before the trial was, or that the study was rolled out, the efficacy of the vaccine, and so that is obviously being monitored now on a longer-term basis. We have got a better record of what kinds of side effects, both mild, moderate, and even severe side effects we could expect. The numbers are pleasantly not huge, but that's part of what the research team now has to investigate, to check exactly how we have behaved as the population. And obviously it's health workers, so they're more accessible to them for follow-ups. So that's the kind of information we will find. I'm sure that over time they will also do periodic studies of the immune response to see how long the immune response is after a vaccination. And at some point, that links with international studies done in other countries to see, for instance, whether it's necessary for a follow-up vaccination. There have been some researchers who've mooted the potential need or benefit of giving a different vaccine as a second dose and so on. So those are all things that follow on as part of a research protocol and a research program. So now we are into the mass rollout, which is completely different. Now we are confident of a vaccine that we know, and we know how it behaves, and we are rolling it out as fast as we can get the supplies to target populations, or what I would call cohorts of populations. So the mop-up of the remaining healthcare workers who were not vaccinated during the Sosonke study is a primary target. And then I'm sure, as everybody knows, we are targeting everybody over the age of 60 as the current cohort that we are concentrating on.
You mentioned errors. What sort of errors do you think may come through, or we're going to hear about?
Was I mentioning that on the system?
Yes.
There are lots of small things that happen. So in the beginning, the total live sites on the first day were less than 100. I think there were 83 public sites and 3 private sites on the first day and the second day. And now we've scaled up to well over 600 sites, plus some of those sites have staff who are moving to what we call conjugate sites, which is where we go to old age homes and that kind of facilities for people with disabilities and so on. And they're also doing outreach services into some vulnerable communities. So during that process, sometimes the power's down, sometimes they're forced to use paper because they are far away from infrastructure. Sometimes they don't capture things exactly right. There have been some errors reported on capturing of ID numbers. There have been issues raised against passport numbers that are not being properly captured or recorded on the system. It's lots of small things that get brought to our attention on an ongoing basis. And then the team follows up to see whether it's a systemic issue or just related to that one patient or client. So I think that'll be ongoing for a long time. And like any system, there are upgrades that get done if there's something significant picked up that can be improved upon. We're also changing some conditions on the rollout program based on science over time. So for instance, we originally had the system programmed for 21 days between the 2 Pfizer doses. There's now been both international evidence and a public announcement that we are going to have the interval at 42 days. So then the program needs to be reprogrammed to send the messages after 42 days. But at the time that's announced, there are obviously already people in the system who've been told to return at 21 days. And it's not always easy to get to all those people to inform them not to come after 21 days anymore, but to wait for the SMS. So, it's the dynamic nature of the changing circumstances, the uniqueness of a province, the relationship between a public and a private site, for instance, that means that there will constantly be things that need to be adapted.
And has any thought been given to the whole registration thing? Because, criticisms, I'm sure you're aware, have been leveled at that system. That in a country with low internet penetration, but also significantly high levels, illiteracy levels, whether it's actually a wise thing to do to insist on that kind of registration system.
Yeah, so a number of interesting things, because now we have some experience. The first one is that I suppose our intuitive response would be what you've reported, and I think the people who are making those comments don't have the benefit of seeing the figures that we are watching every day. What's fascinating is that the province that has registered the most people over the age of 60, by far, double any other province, is Limpopo. Limpopo has the lowest percentage of insured people of all the provinces. It is surely as rural as the most rural of any other province. It has a significant portion of people who are illiterate or semi-literate, and a lot of the elderly people live in very remote areas with not particularly good access to the internet. And yet they have got the best registration of all the provinces, and not by 5% or 10%, by 30, 40%. And yet, intuitively, we would have expected that Gauteng and the Western Cape, where the percentage of the population over 60 that is on medical aids and who have access to internet more freely and accessibly and smaller distances And as far as I'm aware from what we follow, have a greater percentage of people who are literate in the English vernacular would have better registration. And it's not the case at all. So there's something that's not, it's not obvious that people, because they are not as literate in English or have as access to gadgets, that they are necessarily going to register worse off. So that is the one thing. The second thing is that we live in a country that has a very, very human rights-based constitution with very strong laws that protect us in many ways on our access to our personal information, and what we do to people in the health system by way of providing care requires consent. It requires us to keep records. And our financial legislation also requires us, and we're under the fine spotlight at the moment in the way we account for what we do. I'm talking financially now. And if we don't have a system that can count everything and report on everything and make sure that when a patient's records need to be reviewed, we are able to see who gave what dose, of which batch number, on what date, at what site, to whom, and what was the outcome of that vaccination. So that information is available at a patient level, and it can only be at that level if we are registering on an electronic system. It's just not possible to do it on paper. And all of us, for planning purposes, you for the media, for reporting back to the public, we all need to be able to report as quickly as possible. And the only way that we can do that is if we have electronic records readily accessible to us. So the EVDS system is way beyond a registration system. It's a registration vaccination record system with huge checks and balances, and it's also a patient record system for this vaccination. So I know it looks like I'm just defending the system, but everybody who talks to us from a professional level will tell us, thank heavens for the system. And we are happy that it's performing as it's supposed to perform. And we are very happy that the team who looks after it, I mean, I'm the one who gets the credit as being in charge, but frankly, I do the least work of everybody. The team that looks after the interaction with the public and the interaction with us in the professions is, in fact, the one that needs to be praised. And I'm very happy with how all of that is working.
Okay, so you're vouching for the system, but just what are you then hearing, just talking now about the vaccines themselves, what are you hearing from your suppliers? Is it going to get better?
No, in fact, it's not better. I think you've probably seen in the media space, and the announcements have been made both by the European regulator and by the FDA this evening, that the bulk of the Johnson & Johnson vaccine globally is going to be destroyed. So we have significant purchase orders in place. We've been waiting for weeks for the release of the vaccine to get into our program. And it means that until we know exactly which batches, it seems that at least some, if not all, of our vaccine will not be available to us in this program for the next foreseeable future. We don't know what that period will be. And that means that we will have to carry on with only the Pfizer vaccine for the time being. And obviously we have limited deliveries because we were supposed to have had 2 different vaccines being rolled out at the same time. The implication is that the queues move slower, that we are unable to extend to new parts of the program that we had planned, and that people are going to wait longer for their vaccinations. It's not unique to South Africa. It's now going to affect the whole world, anybody who's using Johnson & Johnson vaccine. Obviously, we are constantly in touch with the various regulators involved and the suppliers as a country, and we are doing everything we can to see whether there aren't perhaps other opportunities or consignments that might be available to us. But we are competing with everybody else who's also lost out. So I'm afraid at this stage, things are disappointing, to say the least, and we are going to have to make do with what we can do and do it well in the meantime while we make another plan.
Now, the president is in England at the G7 summit as we speak, and he is expected to push for a temporary waiver on COVID-19 vaccines. Why is that important, and can you shed, or are you able to give us more detail?
Well, yeah, I mean, that's a longer term challenge. So the question is, who gets the patent license to make the active ingredient that is required for the vaccine? And those patents are very tightly held normally. And that means we, as a globe, become vulnerable. Because in case of the Johnson & Johnson vaccine, we're basically dependent on one plant in Leiden in Belgium and one plant in Baltimore in the United States. And as you've seen with the Baltimore challenge, suddenly the whole world's got a problem. So our argument as a country has always been that we don't believe the patent laws are fair to the third world and to the developing countries that are caught in the middle-income countries. And our country has always, well, certainly in the democratic South Africa, has always pushed to get a different set of rules around the patent laws that make it possible for the developing world to make vaccines as generics. So this is a particular situation now in a pandemic where if only a handful of manufacturers are able to make the active ingredient, and an even small limited number are able to do what we call fill and finish, then we are all way too vulnerable. So for the world, it's important. For us at South Africa, it's very important, because we do not fall in that group of countries that is covered by, as the lowest income, and we are not able to compete with the giants in the world's economy. We're caught in the middle, where we have to fend for ourselves against the giants without the kind of help that we would get if we were an extremely poor country. So and we sincerely hope our president and the officials who've been working hard to achieve this managed to make some inroads into that world.
Of course, Dr. Crisp, you're staying with us. Dr. Crisp is the Deputy Director General in the National Department of Health. We're going to take a quick ad break. This conversation continues, and joining us will be two other experts as we tease out other issues that have a bearing on how we manage to navigate this third wave that set in yesterday. Welcome back. This is the Watchdog, and joining me now are Professor Jeff Setswe, a social and behavioral expert from the Oram Institute. Alongside him is Dr. Kerrigan McCarthy from the NICD, the organization tasked with monitoring outbreaks in our country. Dr. Crisp, of course, is also staying on. Now, to set the scene for our next conversation, our senior reporter, Griselda Lewis, visited a family affected by the latest spike in COVID-19 infections. COVID-19, I should say, infections. This is their story.
After it was bad. It was bad.
SABC News is not naming this 53-year-old grieving Soweto woman. That's to protect the identity of her 13-year-old daughter. She says her husband was admitted with pains not synonymous with the virus, but was told that was the cause of death. Since then, their grade 7 daughter has had to be withdrawn from school because she simply cannot cope.
Because very close, Linda, very close. So, I'm affected the school. Right. Then Kaizama, Bampatela counseling for yena, but still, has to be right. When I over Lamuntung, you could fill that form for Abalemuntung. But still, I want to rob you. Raiboots are where it's hitting, and how am I treating about COVID? That the Barunana COVID Madazan Cabalion, Libanabaka Sambabalion. Limontung, everybody on Limontung has about COVID. So, the reports of Rijwang. I think the petals are not something by a plan. Please. if motho o tla ana le cardiac problem ha ba mo ise ko warding ya cardiac ba ska lo mo mixa le batho ba bonang gore ba positive. Like now ke setse a ke sebetse ke dutse le ena fela mo ntlong just struggling nje, but ba modimo o teng ke tshepile yena. Ngwana ka right ha tshwantse re robale, you know, every time o ka se go le robala mo ntlong after 12 fa so shapa re robale because we miss this person ne re dula le ena and ne re dula le ena go the way life ya rena ne le ka teng ka mo ntlong yo a ke go even now.
Experts say children are becoming increasingly anxious and depressed as they witness their parents and loved ones dying from COVID-19 complications. The Teddy Bear Clinic says since March this year, they've seen a 10% increase in children who are directly affected by the virus.
We are seeing an increased incidence of children who are now symptomatic and are actually getting quite ill. But then this is also compounded by their fears because they're not actually quite sure what's going to happen to them. And of course, the fear or the uncertainty around the future is something that could impact on their well-being and, of course, the recovery.
Omar says with children finding it hard to process what's happening around them, there's a need for serious intervention.
We are facing another pandemic, a pandemic of the future generation suffering from post-traumatic stress disorder. So the stress-related disorders, but even internal disorders such as depression, suicide, external disorders where we're going to find behavioral manifestations and also the possibility of numbing themselves from that pain. Just looking at the whole gender-based violence issue where people have indulged in alcohol and said the responses elicited were that it was as a result of trying to numb themselves from pain, escape from the reality of what is actually going on. So I think we need to take heed of this as a matter of grave urgency of what children are facing with and the necessary interventions and responses that are required on the ground.
Professor of Vaccinology at Wits University, Shabir Mahdi, says the virus becomes more infectious. Children, just like adults, are more likely to be infected.
I hate to put all of the blame on a part of people, on a part of the citizens. This is something that could have been avoided. Yet we roll out our COVID-19 vaccines timelessly to high-risk individuals. So this is not just about citizens, it's about failure. It's about failure of us being active in terms of when we got the COVID-19 vaccines into the arms of people. It's about some poor decision-making.
Some of the proposed short-term interventions include psychological intervention programs. Parents and educators would also need to be empowered to respond promptly. Criselda Lewis, SABC News in Johannesburg.
The plight of children being affected by this pandemic. Please remember to follow us at the Watchdog SABC on Twitter and do share your views with us. Now, Professor Senswe, your Criselda there was speaking to a family and the story focused in the main on the plight of children and who are affected. Now, your organization recently did a research on the pandemic's effects on individuals, society broadly. What were the main findings of that research?
Yeah, thanks, Vio, for the opportunity. The social and behavioral aspects of the epidemic have been attended to right at the beginning. And I just want to take us back to the first wave of the epidemic. When it started, the government started promulgating hand hygiene promotion under COVID-19 environmental health guidelines as early as March 2020. The wearing of masks in public was made compulsory from the 1st of May 2020, and social distancing was also made compulsory, in that May 2020 guidelines. And we know about the guidelines that have been set up by government to control gatherings and the lockdown and COVID-19 restrictions on alcohol and curfews and so on. So a lot of work has gone on to sort of prescribe, and I use the word prescribe and regulate because when we were faced with an epidemic, the government came out and promulgated behaviors that should be changed. And this was the beginning of prevention. But the expectation was that the whole society was going to adapt all these behaviors rather than, leaving them to government. For example, if government makes a prescription that for a funeral you only need 50 people, the expectation was that the society and other levels of society would have adopted these behaviors and would, for example, not wait for government to police them, whether they have 50 people, but to ensure even outside a wave 1, wave 2, or wave 3 of the pandemic, that they would reduce the number of people who come to a funeral. They would also practice other behaviors in society. So
we didn't see the behavioral change that, we ought to have seen.
When you do a survey, you'll find that the knowledge levels are high about these behaviors. But the attitude, you start seeing a decline in attitude. The numbers are not as big as the 98% that you get about knowledge. And the actual behaviors go down to around the 70s because some people think that if you have knowledge, you will practice the behaviors. But we know that a lot of people know that smoking is dangerous, but they continue to smoke. People know that if you use a mask, a face mask, you protect yourself, but you still have a lot of people who are not. It's because the behavior that is prescribed is not sustainable. I think we needed to go out as society. There are other levels besides the National Department of Health, like the provinces, the municipalities, the non-governmental sector, and other parts of society that should have helped, to sustain these behaviors and make sure that these behaviors are adapted and become part of our life. So just to say that these behaviors, hand hygiene and wearing of masks, have helped us tremendously in dealing with, for example, the flu pandemic of the winter of 2020. In a normal year, you would get about 11,000 people dying from flu, but because we were using masks and social distancing and hand hygiene, there was a decline in the flu. So there is, value in having to adopt this behavior. So
Dr. McCarthy,
say prevention is better than cure.
Okay, Dr. McCarthy, yours is to monitor this pandemic throughout all the time and as vigilantly as you possibly can. On the back of the things that were being raised by Professor Setswe, and going into this third wave, what can you advise or tell South Africans?
So thanks, Ria, for the opportunity to share with you and your listeners and viewers. The third wave threshold has officially been crossed. That means that we have reached the number of cases, or 30% of the peak of the number of cases in the second wave. So you'll appreciate it's an arbitrary number, but those of you who are following the stats will know that yesterday we had just over 9,000 cases. Today we had just over 8,000 cases. So the number of cases is going up. Now, what that means is it's just the tip of the iceberg. We know that only about 5% of people get diagnosed. A smaller proportion, perhaps 5 to 10%, have mildly symptomatic disease and don't go for a test. The balance of people are asymptomatic. And what that means is that people who are well and healthy but are potentially able to infect other people who are walking around in the community. Now, the only way that we can stop that is twofold. The first is by provision of vaccination, and the second is by observing all these things that Jeff has shared with us. And those are the non-pharmaceutical interventions, as they're called. It's social distancing, wearing masks, avoiding crowded places, making sure there's good ventilation. In fact, at this stage of the pandemic, when we have such high levels, and we're going to see immense climbs in the numbers in the next week or two, it's the safest thing that one can do is to stay at home, not only to protect oneself, but also to protect other people. So as far as possible, to avoid contact with people, and if it is possible, to stay at home.
Dr. Crisp, both Dr. McCarthy and Professor Setswe, are talking or went into great lengths talking about, the behavior of the people of South Africa. But I want to take you back to a comment that was made by Professor Mahdi in that insert that Griselda Lewis prepared for us. Professor Mahdi still talks about, I know you spoke glowingly of, the what people you are working with have been doing and continue to do. But Professor Mahdi still talks about failures. He still talks about poor decision making. Are you saying there's no such?
No, I think that I'm sure it's when we have the opportunity of hindsight, we will all identify things we would have done differently, and I don't think anybody's going to dispute that. And I'm sure that there are people who feel that some decisions that have been taken could have been taken differently. On TV stations, I've been questioned and criticized about decisions around other vaccines, including the AstraZeneca decision. And that was a decision that was taken based on information and advice that was given that some people don't like. The fact of the matter is, and I respect Professor Mahdi, we have worked together over the years. I understand his science and where he comes from. And he's been in the NICD as a director. So he's a respected person. But with due respect to him, he doesn't run the administration and he doesn't deal with the day-to-day decisions in the administration. So, for people who work on the outside of the system and are not involved in the day-to-day pressures that come from lobby groups, politicians, internationals, the people selling the vaccines, the health services, the province, the private sector, all the different dynamics that are involved in making a decision, it may seem that a decision is obvious, but it's never that obvious. The world is a complex place. This is an extremely complex environment in healthcare, and we will make decisions that, in retrospect, we might have taken differently. But right now, with what we have at our disposal, and we need to focus on the now. Right now, we have Pfizer vaccine. And if people ask me, is the Pfizer vaccine rollout going well? The answer is yes, it's going well. It is going along at a pace that we can handle. We will not run out of our pipeline of vaccine if we keep on at this rate, but we cannot accelerate it because we don't have additional vaccine to move into that pipeline. If that changes, had that changed, if the Johnson & Johnson vaccine were approved by the FDA today, the situation would have changed dramatically, because our private partners and our provincial colleagues have all been champing at the bit to increase the vaccination sites and to roll out more vaccines. So it's always easier to sit on the outside of a decision-making process and to be critical than it is to sit inside it and weigh up the options of the many competing dimensions in a decision. So we respect those inputs. We need those inputs, but I don't think we should overreact. And once we've embarked on a path, we must make it work.
But you're not suggesting here, Dr. Crisp, that the person who's outside can't have or criticize you. You're also not suggesting here that you are fine and there may not be instances where you get caught up in the administration and everything you are doing and all of you could be inward looking and forgetting about things that people outside are better placed or positioned to actually see.
Well, I think it's a mix of both, Vuyo. So I think we do try very hard to listen to people, including individuals who write to the president and the minister and to us directly with complaints or issues. And sometimes they have extremely valid inputs to make, and they do influence the decisions we make. But sometimes those decisions, even if that factor is brought into consideration, it has other competing demands on it. So if you have to make a decision between whether to treat patient A or patient B, and you're the only clinician around, you must make a choice. And we as clinicians know that we make those choices all the time. And if patient that you're looking after dies, or the one that you're not looking after dies, while you're looking after one and not the other, you live with the consequences forever. So, I'm not for a minute suggesting we don't want criticism and we don't like criticism. But constructive criticism and moving on from things instead of harping to the things that have already gone, the bridges already crossed or the water's already under the bridge, whichever you like to see it, that is what is difficult. We have to make decisions for today and tomorrow and the next day. And if we've made a mistake in the past, we have to live with that and we have to make a solution around that. So if Professor Mahdi or any other person is critical of some decisions in the past, that's fine. We acknowledge the criticism. But whether to say that criticism is right or not right or whatever, there's probably a balance of both.
Professor Setswe, we have an evening curfew between 11 p.m. and 4 o'clock in the morning. Non-essential establishments such as restaurants, bars, close at 10. Gatherings are limited to 100 people indoors and so on and so forth. Is there something or are there things that we can still do to help or to nudge people to really change their behaviors fundamentally?
Yes, I think we have seen the alcohol restrictions and the curfews, although they sounded high-handed. In December, for example, they reduced the indoor social interactions. They also reduced the motor vehicle accident and the interpersonal violence. And, one of the miracles was, the 2020 New Year Eve, where we did not have, we have very few cases of violence and related admissions in hospitals. So there was space, for the hospitals. But I think, the restrictions, also we have to take into cognizance the economic impact of complete restrictions on the sales of alcohol. But the curfews have to be implemented because we want to minimize the social interactions. We also want to minimize, people getting together and they're infecting others and they're creating situations where many people get infected.
Dr. McCarthy, the second wave came with new and more dangerous variants. Should we brace ourselves for even more dangerous mutations in this third wave?
So that's an interesting question. It's not the easiest thing in science to prove that a particular virus is more virulent, aggressive, or has a higher mortality than another strain. It requires quite a bit of both in-laboratory and evaluation of the existing data to tell. There were some interesting comparisons of the first and second wave, some of which led to suggestions that, in fact, the people who'd been infected with the original strain that spread through South Africa did have quite significant protection against the new strain, but there were what we would call breakthrough infections where people developed a second infection. Now, a more interesting analysis of comparison between the first and second wave showed that populations that had been less affected in the first wave were more likely to be affected in the second wave. So we noticed that in both the first and second wave, Gauteng was relatively spared if we looked at the proportion of population that had been affected. What we're seeing now at the onset of the third wave is that Gauteng is just way streets ahead of the other provinces. In fact, 60% of yesterday's infections came from Gauteng. And that fits with the hypothesis that this virus is sweeping through a very stratified society in South Africa that doesn't mix very much across the different geographic, social, and ethnic, and dare I say, racial strata. So the bottom line is really that if we want to protect ourselves, new variants or old variants, the bottom line is we need to practice non-pharmaceutical interventions at the moment And if one can get vaccinated, one should. If I may add, there's some emerging data from South Africa that is showing, at least in the Free State, which has been in the throes of the third wave for quite a bit longer than Gauteng, that healthcare workers are showing decreased admission rates, suggesting that the Johnson & Johnson vaccine that has been rolled out as part of the Sisonke program is doing its work. It is effectively reducing severe infection and death. And this is in keeping with really good work that has come out of the UK, showing that the Pfizer vaccine has significant protection against the strains of virus circulating in the UK, that in fact it causes a halving in the reduction of severe emergency admission and up to 62% reduction in death due to COVID.
That's good news to hear. If only, of course, we could get the vaccine here as quickly as possible and vaccinate as many people as we can. Very quickly, Dr. Crisper, last word from you. From your conversations with your colleagues in the health department, but also as government broadly, how prepared are we for a worst-case scenario in the event, God forbid, we see severe disease, greater levels of hospitalization, and high death rates?
Yeah, so I think that, as I said earlier, all the provinces and the private sector have been through this twice already, maybe not all at the same levels to one another. And in the Northern Cape, they've already exceeded the capacity of their intensive care units. So to the extent that there are beds and staff available to look after severely ill people, I think some parts of the system will always take strain. But the preparations that were made during the first two, and particularly the second wave, were significant, especially oxygen, and what the clinicians learned and the nursing staff learned, and the way in which the patients were managed during that time is significantly better than at the beginning of the epidemic. Everybody is geared up and has been ready for a third wave for some time. The same in the private sector. So, all they can do is be prepared. But as Dr. McCarthy has said, you don't know how high that spike is going, and you don't know when it's going to spike exactly. So you have to be concentrating on what Prof. Setwe said, and all of us have in fact said, and that is protect yourself. Stay at home if you can. Make sure that when you do go out, you maintain social distancing, you wear your mask, you wash your hands, and you do your best to stay safe and your family to stay safe. That is really the message. Of course, if you can and you are invited to come for a vaccination, and that's particularly now older people, then it's essential to go and get that vaccination. Dr. Chris, Dr. McCarthy, Professor Setwe, thanks to all of you for coming through this evening. Of course, our panelists ending that discussion there about the third wave that is currently upon us. You heard the messages. Do all the things that we've been asked to do since the start of this pandemic. With that, we come to the end of tonight's program. From me, William Vogo, and the crew, it's a good night.